All right, welcome to this rapid-fire explainer on mixed anaerobic infections. If you're currently reviewing for your medical entrance or specialty exams, listen up because these pathogens are absolutely critical. They literally sit right at the intersection of microbiology, pharmacology, and acute clinical management. So we're going to decode these high-yield concepts together and see exactly how they show up in your clinical vignettes. Let's get into it. Here's our roadmap for today. First, spotting anaerobes on exams. Second, the must-know clinical syndromes. Third, treatment rules for above versus below the diaphragm. And finally, major pitfalls and warnings. Let's jump right in. Section 1. Spotting anaerobes on exams. Okay, the term sterile pus is a massive red flag. If a test vignette mentions abundant neutrophils on a gram stain, but absolutely nothing grows on a standard aerobic culture, you've got to immediately suspect anaerobes. Examiners absolutely love dropping that clue. Also, pay close attention to the geographic location. Infections near anaerobic-rich mucosa, we're talking the mouth, colon, or vagina, those are prime real estate. You might also spot mentions of abscess formation, gas bubbling in the tissues, or a patient who's just completely failing to respond to standard aminoglycosides. And what if the prompt mentions a foul-smelling putrid discharge? Well, that distinct smell comes from volatile fatty acids produced by the bacteria, and it's a total dead giveaway. Just keep in mind that smell only actually presents in about 30 to 50% of cases. Finally, remember that these infections are almost always polymicrobial. It's like a bad neighborhood. You'll often see 3 to 6 or even more different bacterial species teaming up. 60%. Take a second to let that sink in. That is the mortality rate for untreated bacteremia caused by Bacteroides fragilis. B. fragilis is, hands down, the most clinically important intra-abdominal anaerobe you need to know. And what's really fascinating here, and honestly highly testable, is the stark irony of where it lives. It makes up only about 0.5 to 1% of your normal colonic flora, barely a drop in the bucket, right? Yet it is the single most common anaerobe found in intra-abdominal infections and bloodstream infections. You simply cannot underestimate this bub. All right, moving right along to section 2, must-know clinical syndromes. Now, Lemierre syndrome represents a rapid, honestly terrifying clinical deterioration that you absolutely have to recognize on test day. The vignette will usually paint a picture of a totally healthy teenager or young adult. They start out with what seems like a standard sore throat, a strep-like pharyngitis, typically caused by a Fusobacterium necrophorum. But then it escalates. The infection invades the lateral pharyngeal space. Your patient suddenly develops severe neck pain and swelling as their internal jugular vein develops septic thrombophlebitis. Next thing you know, those infected clots break off, showering the lungs with septic pulmonary emboli. So if you read a prompt about a young person with a sore throat who suddenly gets a swollen neck and sudden lung infiltrates or cavitation on a chest x-ray, boom, Fusobacterium necrophorum and Lemierre syndrome should be your immediate reflexive answers. Now let's talk about Ludwig's angina. With this one, the massive swelling in the submandibular space changes the whole game. The absolutely crucial point here is that securing the patient's respiratory tract is your #1 immediate priority, period. Even before you think about reaching for the scalpel for surgical decompression or hanging IV antibiotics, you must protect that airway. Ludwig's is a severe bilateral submandibular, sublingual, and submental cellulitis. And guess what? It almost always starts from an infected lower, second, or third molar. As the infection spreads like wildfire, the floor of the mouth and the neck swell up massively. The patient develops trismus, which is lockjaw, and their tongue actually gets physically pushed upward and backward, totally blocking their throat. A tracheostomy might literally be life-saving here. The takeaway? Airway, airway, airway. Okay, whatever you do, please don't fall for the classic trick question distinguishing chemical pneumonitis from bacterial aspiration pneumonia. They love testing this. Chemical pneumonitis, also known as Mendelssohn syndrome, happens acutely. We're talking usually within 4 to 6 hours after aspiration. It's essentially an intense chemical burn, an inflammatory reaction to acidic gastric contents. It is not initially a bacterial infection, which means you give absolutely zero antibiotics unless a secondary infection supervenes days later. You'll often just see a bilateral whiteout on the chest x-ray with minimal sputum. Now, by contrast, bacterial aspiration pneumonia is subacute. It takes days to weeks to brew. The patient's going to have a fever, foul-smelling, purulent sputum, and weight loss. Crucially, look for those infiltrates in the dependent lung segments, like say the right lower lobe basilar segment if a patient aspirated while sitting straight up. This condition is driven by polymicrobial anaerobes and absolutely requires antibiotics from the jump. Let's transition over to section 3, treatment rules for above versus below the diaphragm. If you want to instantly map a question stem to the right treatment, simply ask yourself one question. Is the infection above or below the diaphragm? This elegant little heuristic perfectly divides your empiric antibiotic coverage based on typical regional flora. If the infection is above the diaphragm, like a lung abscess or a gnarly dental infection, you're targeting orodental flora. Think Prevotella, Porphyromonas, and Fusobacterium. Up here, drugs like clindamycin, a beta-lactam with a beta-lactamase inhibitor, or metronidazole combined with penicillin are your go-tos. But if that infection is below the diaphragm, think ruptured appendix or intra-abdominal abscesses, you are dealing with colonic flora. And that means covering the B. fragilis group is absolutely non-negotiable. Now, pay close attention to this number because it literally changes how we practice medicine. Clindamycin resistance in B. fragilis is rising fast. It's sitting somewhere between 30 and 43% right now in the US, and honestly, it's even higher in other parts of the world. So what does this mean for you on exam day? It means you should no longer use clindamycin as a first-line empiric agent for below-diaphragm intra-abdominal infections. Full stop. The examiners are well aware of this updated guideline, and you better believe they're going to test you on it. This breakdown right here, it's an absolute goldmine for multiple choice questions. Mapping out your heavy hitters is crucial. Carbapenems, like imipenem, are your undisputed gold standard for resistant anaerobic infections, bragging less than a 3% resistance rate in Bacteroides. Incredible, right? Then you have metronidazole, which is also fantastic. It gives you stellar coverage against gram-negative anaerobes and gram-positive spore formers like C. diff. But watch out for its major blind spot. It is totally unreliable against gram-positive non-spore formers like actinomyces. Do not get caught out by that. Finally, your beta-lactam plus beta-lactamase inhibitors like piperacillin tazobactam offer really solid broad-spectrum coverage, showing less than 1% resistance in US B. fragilis strains. All right, bringing it home with Section 4, Major Pitfalls and Warnings. Listen carefully. If you see an aminoglycoside like gentamicin, a monobactam like aztreonam, or TMP-SMX listed as monotherapy for a confirmed anaerobic infection, cross it out immediately. They have absolutely zero reliable anaerobic activity. None. Zilch. If you're using an aminoglycoside to get gram-negative aerobic coverage in a mixed infection, you must actively add a dedicated anaerobic drug to the regimen. And as we just talked about, beware of outdated choices. Clindamycin and cefotaxime are no longer recommended as first-line therapies for intra-abdominal infections because their resistance rates are just skyrocketing. So let's tie it all together with this final scenario. Sterile pus points straight to an anaerobe. An intra-abdominal abscess below the diaphragm points directly to B. fragilis. And now you know to immediately cross out aminoglycosides, monobactams, and TMP-SMX. But here's a thought to leave you with. With clindamycin resistance already blowing past 40% and multi-drug resistant strains popping up all over the globe, exactly how long will our current gold standard antibiotics be able to hold the line? It's a scary thought, right? Thanks for joining me for this explainer. Keep questioning everything, and good luck with your studying.